Hello, everybody, and welcome to this evening's event sponsored by Wu University. I think you all that are in attendance will really enjoy the topic areas and the terrific speakers that we have this evening. My name is Craig Norman, and my job here is to be the moderator, to be able to keep things flowing and to make sure that everything is working exactly the way that it should. So here's our speakers. The first of the two speakers that we have tonight is Dr. Tiffany Anderzki. She has a very immense bio, so I'm going to let you read this while I'm just highlighting a couple of the items for this evening. That Tiffany went to Illinois College of Optometry and completed a residency in cornea and contact lenses at Indiana University. And she presently is an optometrist at the Chicago Corneal Consultants, where she's worked for the last decade, which is hard to believe already that it's been that long. She also serves as an adjunct assistant professor at ICO, as well as the Chicago College of Optometry. She has a tremendous background in clinical work, in co-management with corneal patients, and really deals with some of the more unusual cases. And it's a pleasure to have her share that vast amount of knowledge with us. She belongs to a number of different organizations and boards as well. The other speaker is Dr. Melissa Barnett. I think at this point, Melissa needs very little introduction. I'm going to let you read this one as well. I just like to highlight a couple of them. She's the principal optometrist at the University of California, Davis Eye Center. She's really internationally recognized in the contact lens field. I think especially in scleral lenses, where she's done tremendous work over the last 10 years or so. She has written, co-authored a book. She's really authoring things that seem to be in my mailbox every 2 weeks or so. And besides all of that, she is involved actively in the organizations throughout our industry. Her book with Lynette Johns is really one of the very baseline and seminal scleral lens publications that we have, and it's one that all of us should have on our bookshelf. She's involved, as I said, in a number of organizations, and she's received a number of awards. And in her spare time, she spends time with her family, along with cooking, yoga, hiking, and whatever. Melissa, I wish I could actually have 36 hours a day like you do to be able to complete all of that. These are the financial disclosures for both Dr. Andrzejewski and for Dr. Barnett. Neither of these financial relationships will impact anything at all that is discussed this evening. With that, Tiffany, welcome.
Thank you, Craig. Thanks for having us.
And we're absolutely thrilled that all of you are here tonight. I am so impressed with the numbers and to talk about one of our favorite subjects. And both of us practice in clinical care. We see patients. And tonight we're going to talk about keratoconus. This is going to be a lot of fun. So Tiff, next slide. So how prevalent is keratoconus? So if you're in a practice, we want you to be looking for keratoconus in every single patient. So years and years ago, we always heard that number, the value of 1 in 2,000. But if you're looking at the newer studies, it's actually much more prevalent, even as much as 1 in 84, 1 in 700. And if you look at a variety of these studies, and you have to look at how the studies are done and what they're looking for. So now we have the opportunity to do corneal tomography and image the posterior cornea, where we can diagnose keratoconus earlier. And we're going to dive into some newer techniques here in a little bit as well. So this slide makes me really happy. And no, Steph Curry is not my patient. I get asked that a lot. I'm in Davis in Sacramento, California, so not quite in the Bay Area, but pretty close. But I do have many patients with keratoconus, just like Tiffany does. But I love how the awareness of keratoconus is getting out there. And I will have to thank the National Keratoconus Foundation, and please use them as a resource. They have wonderful brochures. They have so many initiatives that can help your patients. But all of us as providers need to get the word out there that keratoconus is actually much more prevalent than we think it is currently. And we're going to see some new studies coming out very shortly showing those increased rates of keratoconus. So here's just looking at a meta-analysis. This is looking at 29 articles, 15 countries, and keratoconus could be 1.38 in 1,000 people in a patient population. Now, I love here, it says that keratoconus is prevalent in both men and women. Very true, because I once had a patient who said only men have keratoconus, not women at all. And I said, oh, do you want to see 10 of my patients this morning? I'll share them with you. They're actually female. If you move on to the next slide here. And when we're looking at keratoconus, we really have to look at many factors. So environmental factors, eye rubbing, atopy, Down syndrome. But if we're looking at keratoconus, family history is so incredibly important. And I believe that we should be examining every single patient who comes into our clinic for conditions like myopia, like dry eye, and also keratoconus. So we really have to rule it out in every single patient. We're going to go over ways to do that in just a minute. So let's look at some of the systemic conditions. So here's a beautiful girl with Down syndrome, which is one of the conditions. We know that Marfan, so Abe Lincoln had Marfan's. Michael Phelps, we don't know. If you want to have some fun on a web search, you can look into that. My kids are swimmers, so look into that. But anyone who has connective tissue disorders of any sort are at risk for keratoconus. Now, sleep apnea, a huge one. Now, if we're seeing patients and we're going into the exam room, I would encourage you to lift up the upper eyelid and look for a floppy eyelid and ask your patients if they have any sleep issues. Many people have sleep issues, have sleep apnea. And if we look at a study of the association between sleep apnea and keratoconus, keratoconus is 1.8 times more likely to have sleep apnea than the general population. And the concern here is that with severe sleep apnea, the risk of death is up to 2 times higher than those without keratoconus. And using a CPAP machine can actually help with severe disease and improve the quality of life in those with keratoconus. And what about high drops? So we know that high drops affects 5% of patients with keratoconus, and the prevalence of mitral valve prolapse in patients with corneal high drops due to keratoconus is 65%. So again, when we're managing, when we're treating patients, it's not just the eyeball, it's all of these systemic conditions that can play a role as well. Now let's talk about eye rubbing. So we know that eye rubbing, we want to stop it. Have you ever had that patient in your chair who has keratoconus and then their sibling is in the corner and you ask, to the patient, do you ever have eye rubbing? And you just look behind you and you see maybe both of them just the vigorous eye rubbing. Now, in all people, we want to avoid eye rubbing, but it's that trauma that creates, and it's the recurrent trauma that can occur and causes inflammation. You know that MMPs are upregulated in corneal tissue and in tears of patients with keratoconus. And we want to avoid eye rubbing. Now, I will add in just 2 cents here is that if someone has ocular allergies and they want to rub their eyes, so maybe someone with keratoconus or just allergies in general, it is important to treat that with some sort of topical eye drop, like a mast cell stabilizer, antihistamine, so they don't have the urge to rub. We can also include other things, cool compresses, refrigerated artificial tears, refrigerate those mast cell stabilizer antihistamines as well, which will be really beneficial. Now, let's just looking at, genetics is so interesting. And if you want to kind of dive a little bit more, I'm diving way into genetics because I think it's fascinating. I'm a little biased towards the front of the eye and the cornea, but I attended a lecture on retinal genetics, and it's absolutely amazing. And the genetics of myopia as well. I don't expect you to memorize these studies. I don't expect you to look at but the take-home point here is that keratoconus is a very complex condition. And there are multiple studies that are pointing to different genes that are associated with keratoconus. And there are many different patients that have keratoconus. And fortunately, we now have the ability to check for this in patients either patients, their children, their siblings, partners, etc. So there are several different candidate genes. Some are associated with corneal dystrophies. In the current test we have now, that's a monogenic test, yes, no, versus a polygenic test, risk score for keratoconus, and some with different corneal thicknesses, and some strictly with keratoconus. So it's so interesting to look at these specific genes. And now we have families looking at the parents, looking at the children, and actually looking at those specific genes that come up on the test and seeing the association. So when do you even consider a genetic test? Well, any patient who has questionable findings, well, what does that mean? Increase in myopia, increase in astigmatism, increase in one eye versus another. Also, what about vision? Maybe reduced vision. So not a 20/20, kind of a weak 20/20, not so great, along with a history of allergies, atopy, eye rubbing, all of the above. What about those patients who want to go into some sort of corneal-based treatment like ortho-K or corneal refractive surgery? And the numbers just don't quite add up. You do a corneal topography, tomography, it's a little, not quite sure about that one. That might be a good time to do a genetic test. And of course, obviously, a positive family history of keratoconus or any family history of corneal dystrophy. So how do you do it? Actually, really simple. In the mouth, a cheek swab. So you take the swab, you twist it around, you send the swab off. 2 weeks later, it comes back. There's information about the genetics. There's a whole report for both the polygenic and the monogenic. And fortunately, there's also genetic counseling associated with it for both the eye doctor and the patient. And a common question is, what happens with this information? None of the information is shared. Patients are not going to be at risk for the information being shared at all. But this can really help us as doctors guide our management decisions. So for example, we have a child, you're kind of debating which myopia management options you want to do. And maybe they're kind of moderate risk for keratoconus. You may not want to choose ortho-K for that specific person. Or someone's interested in refractive surgery and they've been maybe a long time corneal gas permeable lens wearer. They've been out of their lenses and you're wondering whether to do surgery or not. Things are kind of iffy. That's an option. But really, any patient who has a family history, any sort of, even a remote family history of keratoconus, I always recommend to all of my patients to have their children definitely have eye exams and get corneal imaging as well. So we know that prevention is really best. So early diagnosis is highly critical. And why? We want to cross-link. So we want to stabilize that cornea. We want to strengthen it to prevent progression. And so that's why we want to do this genetic testing. That's why we want to see the kids coming in, because we want to avoid the need for a corneal transplantation. So years ago, this is what we had. We diagnose, we monitor, we do all these contact lens and glasses options, and then a patient goes for a corneal transplant. And I had a patient even yesterday who said, my doctor told me I'm going to need a corneal transplant. And I looked at him, I said, well, hopefully not. Your cornea is most likely pretty stabilized at this point in time. And corneas naturally stabilize with time. So we all know that as keratoconus progresses, it's much more difficult to manage. If we have mild keratoconus versus severe, we can easily manage the mild, much more difficult to handle the severe. And we know all of the risks associated with corneal transplants, and especially over time. Now, we do want to preserve vision. So we want to make sure that a patient has the best corrective vision. And if you're interested in like quality of life in keratoconus, there's so many different studies on that, but we should be taking into account the importance of really helping our patients to improve their quality of life so they don't lose vision, but also so that they can have the life that they want and live their best life and do whatever they want in their life. Now, the new mantra, of course, is we want to diagnose keratoconus as early as possible. We want to stop, we want to halt that progression. Then we want to rehabilitate with any sort of options. And we'll talk about a bunch of those options tonight. So here you can see the keratoconus definition. You can take a look at this. This is published, it is standard, and we know it's that abnormal posterior ectasia. So every time I do a pentacam and I'm able to image the posterior cornea or any imaging, even using OCT, I think, oh my gosh, it's like cheating. It's amazing. I can see the posterior cornea. We want to look at abnormal corneal thickness distribution. That's a diffuse or global pachymetry. So at one of my locations, I don't have the fancy dancy instrumentation, but I do have an autorefractor, and I've trained my technicians to look at that autorefractor and look at the Myers on that autorefractor and look at the numbers. So looking at corneal curvature, and I'm really looking at 46, but if it's 48 and looking at the astigmatism and myopia, I'm definitely thinking I want more information to determine if they have corneal ectasia or keratoconus. We also know that keratoconus is mostly a bilateral condition. There have been some rare cases of unilateral conditions, if you want to get into that whole thing, but mostly it's a bilateral condition. So what about the advanced technology? So we have corneal topography, we also have corneal tomography, we have anterior segment OCT, corneal hysteresis. We also have barometry. And if you look at how much this technology has progressed and improved in the last, 10, 15 years, it's been incredible, absolutely amazing, and so fun. And we're going to talk about different technologies to diagnose and also different technologies when we use and fit contact lenses.
So talking about those technologies, the most common thing, as Melissa mentioned, is that we have diagnostic imaging. We have corneal topography. So average corneal topographers that many of us may have in our practice is a placido disc where we have those Myers. So when the Myers become less circular, more egg-shaped, that can kind of point to a protrusion or irregularity. So early signs on a placido disc topography are kind of seeing these skewed, kind of curved astigmatism. We're not seeing a symmetrical bow tie anymore, and it kind of looks like a lazy 8 pattern. And that can be a key that, there's something else going on that we need to dig deeper into. Ultimately, with corneal topography, it can present a couple different ways as far as, how keratoconus looks. Sometimes it starts out as that bow tie and it skews until we see that hot spot that we're so familiar with. So don't let just seeing a hot spot make you think that, oh, only that is keratoconus, but any irregularity in that bow tie shape should signal a concern that there's something else going on. Ultimately, when it comes to topography, it can also be somewhat misleading to diagnose keratoconus in its earliest stage possible. So as we see on the left, this is a patient that has a placido disc topography. Ultimately, looks like they might have some, somewhat regular-ish kind of oblique-ish astigmatism. I might be able to convince myself that maybe things are a little wonky just because of some dry eye. But, that's only looking at the front surface. As Melissa mentioned, the key is the back surface of that cornea. And so once we use tomography, where we can look at that posterior elevation map, here we see that, it's not as normal as we once thought. And this is how we can really diagnose keratoconus early. So if you don't have tomography in your office, if you're seeing something that just doesn't add up, whether it's using the autorefractor like Melissa mentioned, or just a regular placido-based topography, by all means refer to get more information. In addition, the definition of keratoconus is to look at pachymetry. So corneal thickness less than 500 should signal that there's something going on there. And, using a ultrasonic pachymeter is great and all, but we're not testing the same spot at all times. And so it's not perfectly accurate. So using global pachymetry, such as, from tomography or from an anterior segment OCT map, that gives us a better overall view of the corneal thickness. And it's repeatable on that instrument. But some of us don't have that fancy technology. Melissa mentioned one of her offices doesn't have that fancy technology. One of my downtown offices doesn't have all that fancy technology either. We're there only part-time, but we still see a high volume of referrals. So that's where you have to consider all the other things that go along with keratoconus, particularly paying close attention to your patient symptomology, shadowing, monocular vision, monocular polyplovia, seeing multiple images, the glare and flare and halos at night, Is it a patient that constantly is changing their eyeglasses? Are you seeing them back instead of once a year with a minor shift in prescription? Are you seeing them every 6 months or every 4 months, them noticing changes in vision? Or are they coming in saying, I just got glasses, 5 months ago and they're not working well anymore? Increase in myopia, especially astigmatism, especially oblique astigmatism and asymmetrical astigmatism should signal, is there something else more going on there? And as Melissa already mentioned, kind of looking at the corneal curvature, using some sort of guideline, whether it's 46 diopters, 47, definitely by 48, there's something questionable there. But then we have all of the clinical signs of keratoconus, which many of us are all familiar with. So keeping a lookout on slit lamp. But by the time we're seeing some of these signs, we're no longer in the mild disease. This is definitely usually more moderate in severity. Another very non-technical tool, as Melissa can share with us, is about retinoscopy.
Right. So I think it's important that all of us are using our retinoscope. It's such a helpful tool if we're fitting a contact lens and doing a starting point, and it's so useful for so many other things too. So this is actually a video thanks to Lynette Johns, and this is over a scleral lens, but you can see that scissors reflex. And this study is looking at the sensitivity and specificity of retinoscopy, and it's actually compared to a pentagram, and it can be very, very useful. So at the one location where I don't have the fancy tools, I can use retinoscopy, and I use that along with all the other things that we mentioned to help in the diagnosis of keratoconus, and then do additional testing, imaging, etc.
So in addition to retinoscopy, as we mentioned, you can use anterior segment OCT for detection. And using global pachymetry map, some of the newer instruments has this ability to also measure epithelial thickness. And so what you're going to see on this map is we're going to see kind of this donut pattern where thinning is occurring over the apex, and that kind of highlights the cone because the epithelium is going to thin first over the apex of the cornea. And so this can kind of highlight that early distribution and may help diagnose early disease earlier, which is kind of our goal here. Also, there's the option of corneal hysteresis. Don't want to go into this too much detail, but the biggest thing that we see with corneal hysteresis, which is measuring biochemical properties of the cornea, is that there's this deformation amplitude, which is more sensitive. So looking at that bottom, as the air puff hits that keratoconic cornea, we're seeing that there's a bigger deformation in the shape of the cornea, and then it rebounds, which indicates that that cornea is pretty fragile and much thinner. And then we also have, when it comes to other high-tech technology to diagnose keratoconus, we have aberrometry. So we know our phoropter, when we're doing, refractions, we're measuring lower order aberrations, such as astigmatism, myopia, hyperopia, and so forth. But higher order aberrations is what causes the glare, the flare, the halos, the visual distortion that our keratoconic patients witness. And so what that brings us to is corneal treatments for this disease. So we've got many options for treating. The biggest thing is to diagnose them early, perform corneal cross-linking, and then next step is, treatment options for their vision. Once we've stabilized that cornea, it opens up new worlds for vision correction. And so we have everything from glasses for mild disease, contact lenses, corneal inlays, topography guided ablation, and what we're hoping not to get to the point is cornea transplant, but then again, that can always be an option. But when it comes to keratoconus, what we have to keep in mind is when do we need to monitor and when do we refer? And so as Melissa mentioned, we have some risk factors for KC, the biggest being family history, of course, that plays a huge role, as well as age. We know our younger patients, we need to watch out for more than our older patients. Not saying that our older patients can't progress, but, we usually can catch the disease earliest in our younger patients, as well as, that positive family history. So Melissa, tell us a little bit more about how you might use genetic testing for, do you monitor this patient or do you refer?
Exactly. So it depends on, of course, what type of practice setting you're in, but this genetic test that we have, it gives that summary of the risk for keratoconus. So it's not, it's not saying this is what you need to do if the patient has keratoconus, but it gives a risk factor. So for example, if you have a 5-year-old patient who's at high risk with a family history of keratoconus and other factors, they might have some astigmatism, they might have some allergies, they might have a connective tissue disorder. That is someone that I'm going to want to monitor much more closely, and even potentially send for a cross-linking consultation. And I want to see them much more than once a year. So it depends on all of the factors. But again, the goal is really to cross-link, stabilize the cornea. Now, in addition to all the genes that you could see there, if you kind of looked at that bottom right-hand side for corneal dystrophy, it gives that monogenic, the yes/no. So here's the case, and it goes over, why this is important. So we have a mother, we have an 8-year-old son. The mom had been diagnosed with unilateral keratoconus, had cross-linking in the right eye. The 8-year-old son, looking at the topography, corrects to 20/20. If you move on to the next slide. And then you can see the patient actually had a risk score of about 50, indicating a moderate risk of keratoconus. So it is important, so important to image the cornea, to do this genetic testing, again, to cross-link, to stabilize the cornea before they progress, and in order to prevent a corneal transplantation. So this is just looking at, just the panel. Anyone with progressive ectasia should undergo cross-linking no matter what age or level of vision. So in our practice, we have multiple corneal specialists. It's also a referral practice like Tiffany's, where we have corneal specialists from outside as well. And so I'm always having these conversations. We're sending patients back and forth, but I will encourage you to go beyond the corneal specialist. It's other specialists that we need to talk to as well, for example, sleep specialists, primary care, et cetera. So the FDA approved cross-linking. This procedure, epi-off, epithelium is removed, and it is kind of a time-intensive procedure, but it works extremely well. And fortunately, we have it in the US. It took so many years, and we have many patients going overseas, but it is a safe procedure. If you kind of go on to the next slide here. And the coverage, I would say, is so much better. It's about 96% in the US for cross-linking. So even 2 years ago here in California, the coverage was not quite, in my area of California, the coverage was not quite as good as it is now. So it's actually excellent coverage. So if you do see any sort of progression, and the progression depends a little bit on the insurance company, but for example, an increase of 1 diopter in the steepest K value, an increase greater than 1 diopter in regular astigmatism, myopic shift, and looking at a decrease in the back optical zone radius in the rigid contact lens wearer. So in my patients, in my notes, I'm actually writing like the steep K, I'm writing the amount of change in astigmatism, just under the impression for myself. I think it's helpful to have all those values for when I see the patient back. I include corneal thickness as well. And then it can also be helpful if you're sharing the information and consulting for a cross-linking consultation. I think you're muted.
Sorry about that. So despite advances in diagnostic tools, keratoconus, as we mentioned, is still often diagnosed in a relatively late stage. So the key is to try to catch it sooner so that we can preserve patients' vision and keep them in contact lenses and simpler contact lenses longer. And as Melissa mentioned, when these patients are younger, they have a rapid risk of progression. And so, we want to refer them early. So if they are younger than 18, generally recommend referring them within 6 weeks to a specialist. And if they're over than 18 and you suspect progression or keratoconus, refer within 12 weeks so that we can really nip this in the bud. What COVID has taught us is that, it can progress rapidly. When things shut down and we couldn't perform cross-linking, keratoconus for our younger patients definitely got worse at an exponential level. And so we need to address that. And so cross-linking is approved for just about anybody. It really comes down to making sure that we do have progressive disease thanks to insurance carriers, and looking for that 400 microns of central corneal thickness, or the minimum. But keep in mind that that's not a full-all because ultimately they can swell the cornea during this procedure to get them up to that 400 microns to still safely perform the procedure. So ultimately, if they are young and you're thinking of this diagnosis, or you see keratoconus and first-time diagnosing, especially if they're a young individual, definitely refer, because that comes down to, this overall continuum of care for these patients. So it starts with cross-linking, and then the next thing is vision rehabilitation. And so we have a number of different contact lenses that some work well for earlier in the disease spectrum. Others are going to work better much later. And so the goal is to keep these patients in contact lenses as long as we possibly can to preserve their vision. So when it comes to irregular corneas, the question is, we have all these toolboxes in our, or these, options in our toolboxes. So where do we start? And so when we look at the disease from, a subclinical level, we have all of these other options: glasses, off-the-shelf soft contacts, corneal GPs, and hybrids. And that's going to look different as these patients progress in the disease. Soft contact lenses do work as long as there's mild irregularity, if the topography is somewhat symmetrical, and if these patients kind of think that their spectacle vision is pretty acceptable, then you can consider a soft lenses. Irregular corneas don't always have to equal GPs. GPs are great though. They've been around for ages. We know they work. We know they have superior optics, but we are aware of the drawbacks for our patients of the adaptation time, and depending on, their work environment, they may not be ideal. And so that brings us to hybrids, which can kind of mix the best of both worlds of having that sharper visual acuity, a more stable lens thanks to that soft skirt. And in the year of 2022, these lenses are quite healthy. When fit appropriately, they are high decay, they have UV blockers, and we can improve wettability with HydroPeg to really enhance less friction with the blink. And then today's hybrid lenses also incorporate reverse geometry in them, which helps the tear exchange. So with hybrids of the past, they used to have a bad name because they would bind to the cornea, cause hypoxia, cause neovascularization. With today's hybrid technology, we don't see that as commonly when they're fit appropriately. When it comes to the normal cornea lenses, we have the first generation lenses, and those do work for mild corneal irregularities as long as it's central. But that's kind of a hydrogel skirt, so not ideal as far as preserving ocular health for these patients that might be wearing these lenses for 12, 14 hours a day. The second generation lenses for the normal cornea, generation 2, they do have a sci-high skirt, but they have an aspheric GP. And so although it's meant for normal corneas, it does have a prolate shape. So for your very, very mild or early or subclinical keratoconic patients, this can actually work quite well when you don't have a true protrusion and you just have maybe those posterior surface changes alone, where they're 20/20 in spectacles, they feel like their vision is okay, but they have kind of that visual noise or poor quality of vision. When it comes to the normal cornea technology, the third generation is completely meant for normal corneas. And although it's customizable and great, this is not a lens you want to reach for any sort of irregularity. It only is successful on those that are 100% normal. So we're going to kind of skip over this case here just for the essence of time, but this was a patient that you see that had a pretty normal surface, saw well with glasses, but that posterior float is what led us to fit her with a hybrid lens, and she did quite well with that fit empirically. But the key to keep in mind is when you're using this lens specifically is, do the refractive astigmatism and the corneal astigmatism, do they line up so that you can be successful? When it comes to mild keratoconus, we have a little bit different options. Custom soft lenses, corneal GPs, and hybrids work best in this group. The specialty soft lenses, there are two classes. We can have the increased center thickness to mask that irregularity, or aspheric designs to limit aberrations. And there are so many different options as you see here. And we know the advantages of soft lenses. We use them daily in practice, but sometimes once we get higher astigmatism, the fluctuation in the blink and the unstable vision can be undesirable for patients. And again, that's where hybrids can provide a little bit better vision and better tolerability, even than soft lenses or corneal GPs. When it comes to hybrids, we know that, With today's technology, they provide more stable vision on the eye because we have that tear layer underneath. There's less movement with the soft skirt, but they do require special handling. And so great option to consider for the irregular cornea. The first generation design is more prolate and works very well, but again, hydrogel skirt. So keep in mind that for DK. But our second generation has both a prolate design and a oblate design. And so with that, we can now fit more geometries of different shapes of the eye. Small central cones do really, really great with the early generation design, as you can see here, versus the more advanced will do better with the newer generation designs. And even in today's world, we can design hybrids empirically. Here's some things that it takes to do that. You get that information if you can perform a manifest refraction or a GP over refraction and you call the lab, they can help you design that first lens empirically, and then the fit happens once you have that lens in the chair. The ideal fit is to vault the cornea centrally, and that lens, as it settles, should have at least 50 microns of clearance at the end of the day. We have some feather touch in the inner landing zone where the GP makes contact with the cornea at that junction of the soft skirt, and then the soft skirt should have some mild movement or perceptible movement without any staining. With the nuances of this design, it doesn't fully vault the cornea. It does come into light contact, so we want to be respectful of that because the weight is shared between the corneal mid-periphery, as you can see here in this OCT, with 70 to 80% of the pressure of that lens should be in the skirt, while only 20 to 30% should be touching that cornea. And so that's why many patients find that hybrids do feel more comfortable than a corneal gas permeable lens. But with that, a flat fitting lens definitely needs to be rectified, or any lens that causes corneal staining. So we want to be sensitive to that. And then also we need to keep in mind that you want to be careful with that skirt because the side skirt does provide some early lift, but if you go too steep, that whole lens can crash down and cause lens binding, which can cause patient discomfort later in the day. And so this is kind of the basics of troubleshooting. And then HydroPeg is standard on all specialty lenses for the irregular cornea that come with the SiHy skirt. And so that works really well for your moderate keratoconic patients. But as we're starting to see that cone protrude more and become wider and more inferior displaced, sometimes we also need to consider scleral lenses, and that's where they can really shine. So there are a number of patients that will do really great with hybrid lenses, especially your quote unilateral cones, those patients that maybe only need a specialty lens in one eye, that are failing with GPs, they have piggybacks that they're not loving, or they're having some difficulty with handling of sclerals. Sometimes that's a great option to consider, or even your first time wearer, especially patients who have only worn soft lenses. This can kind of, bring them into the world of specialty lenses and ease them in and not be quite so daunting. So hybrids do have a number of advantages, as you see here, but the other thing to consider is that, kind of the cheap man's hybrid is piggybacking. And that's where sometimes you can have a little bit more customization of the size and the shape of that gas perm using this method. But of course, some patients are not key in putting in two lenses. There are a couple different fitting approaches. You can fit the GP first and slide the soft lens under, or vice versa. But hybrids are great, but they do have some disadvantages, as well as all lenses in our toolboxes do. And so, definitely not for everybody, but hopefully through today's lecture, you'll have a better sense of who you might want to consider these lenses for. Given that my co-lecturer is Melissa, a world phenomenon in scleral lenses, Melissa, share with us when you might consider sclerals and why sclerals are so key for our keratoconic patients.
Exactly. And great job covering the hybrids. I have a quick question for you. So I saw some slides of like 2020, 2025 vision, but in my experience, patients are getting like 2015, 2010 vision. What about for your patients? Do you ever get those levels of vision?
With hybrid
With a
lenses?
hybrid lens.
Oh, absolutely. And because that soft skirt helps it center, I have had some patients that, if I've refit them from a corneal gas perm lens, because of that pure centration of that soft skirt, sometimes they actually get better vision than what they thought they had. So it works really well for the right patients.
Exactly. So moving on to scleral lenses. So scleral lenses, they involve the cornea, land on the scleral conjunctiva, provide really good comfort, great vision because we have those gas permeable optics. They can be customized in so many different ways. We're going to be talking about some of them tonight. And there are different ways of fitting scleral lenses. So we can use diagnostic sets. There's different methods and technology that we're going to be talking about tonight. But we have to take into account scleral shape because the lenses can decenter inferior and temporal. And this is really common based on just scleral shape in general. So when we're thinking like hybrid scleral, which one is it? I always look at the cornea. And as we know, many people who have keratoconus also have significant dry eye disease. So a scleral lens with that fluid reservoir, which bathes the cornea all day long during the time of lens wear. And I'd say bathes anything under it. So that could be the conjunctiva as well, could be the way to go. But if they don't have significant ocular surface disease, we could choose another one of those tools in our toolbox. But there are many different great advantages of scleral lenses. They can protect, but I would not use them as a protective option, but they create really excellent vision to correct all sorts of corneal irregularities. We can use scleral lenses for even severe ocular surface disease. We can also use them for any sort of refractive error, including presbyopia. So let's look at corneal shape here. And here we can see that we do have multiple types of corneal shape in a patient who has keratoconus, and one who maybe even has had a corneal transplant can definitely have all sorts of different shapes. So corneal transplants are like snowflakes, right? Corneas are like snowflakes. They're fascinating. They're so interesting. They're all completely different. So we can have prolate, we can have oblate shapes. And now we have these advanced technologies with scleral lenses in order to fit the cornea and the front surface of the eye.
And not only do we have oblate lenses for sclerals, but we also do for hybrids. And so that can really help for patients that have these peripheral lifts where we need to get over these things and still provide them with lenses. So not all patients, depending on their hobbies, especially this patient here who was an MMA fighter, scleral seemed like a great option, but we were definitely worried that he insisted that he must wear his lenses while fighting and didn't want to take the chance of, hurting his eye with a scleral lens if he were to get hit just right. So that's where hybrids can work in those situations. And they can also troubleshoot the oblate design when you're having difficulties fitting a keratoconic cornea to give more mid-peripheral lift. But at the same time, hybrids don't always work, especially, in a patient like this where we have a steeper cornea and the lens decenters, they have some issues with flare and glare and things like that. So sometimes, as Melissa mentioned, sclerals can really come to the rescue. And there are several different ways of fitting them. We have diagnostic fitting, scan-based fitting, and impression-based fitting. But ultimately, when it comes to sclerals, there is a typical optimal fit of vaulting that cornea by at least 150 microns to 200 microns after settling at the end of the day. We want to clear the limbus and align evenly on the sclera without blanching or impingement. But we all know that's easier said than done. And who knows that better than the person that wrote the book on it? Melissa, share with us some insights about scleral shape and some of the complexities of fitting scleral lenses and how we can take that into consideration for fitting a lens optimally to help our patients.
Yes, we've learned so much about scleral shape. I actually have a whole entire lecture on scleral shape because I think it's absolutely fascinating. And many thanks to all the researchers who are doing this research on scleral shape. So we know that scleral elevation, it's not spherical. It's typically asymmetric or toric, and it has to do with the insertion of the eye muscles. And so when we're looking in terms of sagittal height, and look at this gorgeous image here, we can see that the nasal sclera is higher and flatter, and the temporal sclera is lower and steeper. And this happens as we move away from the limbus. So that's why if we're looking at a scleral lens on the eye, white light, slit beam with fluorescein, we're going superior nasal, less clearance, inferior temporal, more clearance. And if you're actually looking at a bunch of scleral lenses, you can see that many are slightly inferior temporal decentered. So looking at this corneal scleral junction, and again, this is just like a touch on scleral shape because there's so much to it, but the definition is the angle at the junction of the cornea and the sclera. And this is why we don't just order scleral lenses empirically. We don't, not quite yet, but we'll talk about some technology that we're using. And the sclera continues as almost a straight line or a tangential a profile adjacent to the limbus. So if we're looking at OCT, using OCT, most eyes, around 80%, have an anterior scleral angle that is within about 3 degrees of the limbal angle, and the most common transition is 2 and 3. So here you can see the corneal scleral junction. There are regional variations in corneal curvature based on the muscles of the eye. And so how does this affect the fit optically? So if we don't have a lens that's perfectly centered, it can affect higher order aberrations. Also for presbyopia, if we're correcting for that, it can also just affect vision in general, and also physiologically. So we want an even landing zone. We want that scleral lens to land evenly on the scleral conjunctiva. So can scleral toricity be predicted by corneal topography? Well, we're learning more, and there are different studies. So here's one of them using corneal topography to predict scleral toricity. And what we've learned from all this take-home point is that really the more irregular the cornea, the more irregular the sclera, but it's not necessarily going to be lined up. So we can have with the rule irregular astigmatism on the cornea, could be against the rule irregular astigmatism on the sclera. And now we're using many different instruments. We have scleral profileometry to actually measure that scleral conjunctiva. So here is the scleral shape study group, Greg Denaire and group, excellent study. And years ago, looking at the back surface toricity of scleral lenses, we didn't even have toric sclerals, but now we know, and this is one of the studies that helped us share this information, is that most scleras are somewhat irregular and only about 5.7% are spherical. What does that mean when we're fitting scleral lenses? Most of the scleral lenses should be customized and not have spherical haptics. And what about looking at the shape of the cornea? I love this review by Dottie Fidel. And if we're looking at the HVID and the VVID, so the horizontal visible iris diameter and the vertical visible iris diameter, blah, blah, blah. We can see that typically HVID is greater than VVID. And I would encourage you tomorrow to look at 10 patients and see if this is true. They don't even have to be contact lens wearers, but once you start looking for it, you're going to see it all the time. And then we're another great study here. So in greater ectasia, we have more asymmetric scleral shape. So if you have a cornea that is highly irregular, the sclera is most likely going to be highly irregular as well. Okay, so when we're fitting lenses, what do? We select the lens diameter and choice. We do scleral profileometry. Tiffany, do you use scleral profileometry in your practice?
Funny you ask, I do. I find that, it can be very useful. It kind of gives us a snapshot as far as their scleral shape. I mean, once you put on a lens, that kind of gives you an idea, you kind of deduce it, but I find that it can definitely, open your eyes into what you're seeing, especially as I've used it in practice.
Yeah, I think it's pretty amazing having 500,000 data points and using that information. And if we kind of move on to the next slide, but very great point that you had is that you have to put a lens on the eye as well. And then we want to choose the diameter. We want to choose the design. When we're looking at an ideal scleral fit, it depends a bit on the corneal condition, the diameter of the lens, what you're fitting the lens for. Is it ocular surface disease? Is it corneal irregularity? We want to choose the base curve. If a company has a fitting guide, I would highly recommend you to follow the fitting guide when fitting scleral lenses for greatest success. And then using that vault reduction method. So having a lens and actually going down in sagittal depth, because if we have a lens that's touching the cornea, it's a little bit difficult to determine how much we need to increase the sag. But if we have a lens that is vaulting and going over the cornea excessively, it's easier to determine how much to decrease that sag. And we know that we're fitting on corneal sagittal height. So I love this picture here. The images, we can see an HVID of 11 millimeters. We have a sag of 2530 versus an HVID of 12.6 with a sag of greater than 4,000. So really important images here that share that we have to consider what is the HVID, what are we fitting, and selecting a lens from there. And we know that the corneal apex is not always the most elevated area. So here you can see a patient who has limbic keratopathy. And we know in those who have any sort of nodules or any sort of irregularity, that the scleral lens needs to go over, vault over the entire cornea without any bubbles, and hopefully land evenly on the scleral conjunctiva, as you can see with these beautiful photos from Tom Arnold. But really, in reality, not all scleral lens fit is as beautiful as these images portray. So tips for perfecting the fit: look at the diameter, really choose a diameter. And sometimes I'll kind of increase, I'm talking about shoes all the time when I talk about scleral lenses, high heels, snowshoes, many pairs of shoes, breaking in shoes, adaptation, but using a wider landing, so having a wider distribution of the scleral lens actually has less pressure, and that can be really helpful when fitting. So you can always increase that landing. So here you can see an example of a 16 millimeter and a 17.5, and these are beautiful pictures here. And sometimes we all wonder, like, where does the landing start? And yep, here you can see the landing on the limbus, and the ideal landing about a millimeter or so past the limbus. So if you have this technology, if you have OCT to image it, go ahead and use that. If you don't have it, it's okay too. You can still fit the lens. And we, of course, want to clear the limbus. We don't want the lens to touch on the limbus, but we also do not want excessive limbal clearance as well. So we want to vault the cornea, vault the limbus, and land on that scleral conjunctiva. So here you can see some kind of nice images of excessive limbal clearance. We can get all sorts of debris under the lens. We can have conjunctival prolapse, as you can see from this nice image here. And we want to avoid that if possible. And of course, we want to align with that scleral conjunctiva. So here you can see, again, talking about shoes, we can talk about high heels. We have toe down, we have aligned, we have heel down images. And looking at this diameter, we'd really want to increase that diameter. And let's talk about the landing zone. So we do want a linear landing zone. And you might say, well, what is that even? And research shows that the paralimbal sclera is linear or straight, as you saw in those prior images, rather than curved. And we really want to align in that area so that the lens distributes evenly on that scleral conjunctiva, so the patient has a very comfortable fit, good vision, also their eyes nice and white. It's not red or injected or anything like that. And they can wear a lens all day long. So here we have a lens with a toric periphery. And again, we're not talking about like front astigmatism on the front surface, we're talking about back surface toricity. And we really want this lens to align evenly with the scleral conjunctiva. So again, looking back at those studies, most lenses will require a toric periphery, and this distributes the lens evenly. So it has a more stable fit. Scleral lenses don't tend to move a whole lot. They don't have a lot of tear exchange, but this helps. It reduces blanching and bubbles, edge lift, decentration. The lenses actually look beautiful, just aligning very evenly, helps with comfort, and again, provides really good vision. What about those lumps and bumps? Like everyone has pinguecula. We have many patients, I'm sure you do too, Tiffany, who have blebs and pterygium, and these can really interfere with the fit. in all sorts of ways. So there are different ways that we can go around this. So we can vault over the area. We can make the lens super small. We can make a notch. We can make an elevation within the lens. There are many different techniques of avoiding those lumps and bumps. But sometimes we have, I'm just thinking of specific cases here, but we have many very advanced lumps and bumps, specifically glaucoma tubes and shunts and blebs. And we don't want to cause any compression or irritation in those areas. So here we have another fitting option, which is, I was curious, Tiffany, if you ever use scleral profileometry, to actually measure and to vault and not compress those areas.
Exactly. I will tell you that you're amazed at how much lumps and bumps you see once you start fitting scleral lenses, because the eye just highlights them if you're not aligning appropriately. And so that's where profileometry can really shine. It takes the guesswork out of where are those lumps and bumps, how deep are they, what axis and orientation, how wide. So it can be very useful in doing that. But of course, as the other slides show, there are ways around that. But where profileometry can shine is it takes, the science into scleral lens fitting, keeping in mind scleral shape. Because this study here showed that it takes approximately 60 cases before there can be a significant reduction in trial lenses and reorders necessary. And so it does take practitioner experience. And this is where, this can really give you the edge in fitting lenses. We do still fit lenses diagnostically, but now we can do instrument-based fitting. So we can use that profileometry information to tell us about the corneal shape, about toricity, about asymmetry. And we can use that to help us aid in our diagnostic fitting and how to design the lens. And now we can even use it to design freeform custom lenses empirically. Empirical fitting for GPs is really, really well known, and whether it be a toric or multifocal or spherical, we can even do it for hybrids. We're seeing here that this report from Contact Lens Spectrum showed that hybrids can be fit 50-50 diagnostically versus empirical, but sclerals are still mostly diagnostic. And that's because, it's slow sometimes to adopt this as an extra equipment, and then it's an extra cost for our practices. But if it's something that you're considering and investing in, it can be certainly worthwhile to streamline your fitting and enhance your practice, as we can, kind of see here all these different elevations. And some of the software can show us simulated fluorescein designs and help us customize and see that as we go. There are 3 major devices at this point in time: the Eaglet Eye Surface Profiler, the Visionary Optics SMAP 3D, and the Oculus Pentacam corneal scleral profile. 2 of these, the top 2 use raster stereography, which uses fluorescein-based images to help provide and get that information, or shine flow tomography. And it can give you a 16 to 22 millimeter scan, which can give you plenty of data to design a scleral lens. And then we have profileometry-based freeform sclerals. There are a number of companies that all you need is the image and some sort of over-refraction scleral lens, RGP, even a manifest over-refraction, and you can design a scleral lens so that first lens that you're putting on the eye is already customized for the patient and has their prescription. When it comes to instrument-based fitting, as I mentioned, you can use the profileometry to guide you versus you can empirically design a lens. Those lenses are more costly, but at the same time, what we learned via COVID is some patients just don't want a lens that's been on many patients' eyes. And sometimes we just need to expedite and get a patient seeing as quick as possible. Melissa, do you use profileometry design sclerals? Do you do empirical fitting in your practice?
Yeah, so I actually think it's been some of the most exciting scleral lens work in the last few years. We have 2 scleral profilometers, so I'm completely spoiled. But using this, even a patient who had a good fit, the fit looked good, the comfort was good, but maybe I could make it better. And so patients now they say that their vision is better. I think the lens is more aligned than it was before, that they can wear the lens longer, more comfortably. I think the fits are just absolutely gorgeous. And And many different designs can connect directly to the company. You can also, as you mentioned, definitely use this information to design a lens, but really important to put a lens on the eye because we still want to check the power. I mean, there are some people who order a lens and then use that as the diagnostic lens. That is an option. But if you do want to use this in practice, I tend to put one lens on the eye. And of course, we have guidelines for disinfection of the lenses that we can use in practice. But I've been incredibly impressed time and time again with how well these designs are being used. And some of my patients have very complicated eyes, and having this technology is really great. Now, then you might ask, well, what if it doesn't work? Or what if you have a 10 millimeter bleb? What do you do? That's when we reach for our impression-based. Yes, this is my practice. So that's when you reach for an impression-based lens. So here we have an eye. You can see that beautiful blue goo. And it is the most customized option that we have at this time. So fit within a few microns. It uses very specific elevation-based technology. That was a gorgeous, gorgeous impression. And here you can see how it scanned, and it fits like a glove or a custom dress or a custom shoe if we want to stay with the shoes here. But we have these devices that can really align to the entire ocular surface. And if you look at the next slide, I believe that's some studies that just show all the benefits of this technology and how it can help so many of our patients with very complicated eyes. So you can see that how that lens is kind of decentered a little bit there. So there's so many different options. So of course we can have multifocals, we can put prism in there, we can have HOAs, and we can have a larger diameter lens, which is very helpful for those for ocular surface disease. So many different indications. You can kind of go to the next slide here. And this is the study I was referring to, showing a significant improvement in vision, average of 4 visits to finish the process. And for those who have very advanced irregularities, this could be a great option. So here you can see some beautiful images, and yep, moving on.
So ultimately, you may say, why does all this matter? And so, just to bring this home, the nice thing is we are seeing, due to all of this technology, due to corneal cross-linking, that we are seeing a decrease in cornea transplantation. In 2020 alone, we're finally seeing that the number of PKs has decreased in comparison to endothelial keratoplasties. And the primary indication for PKs still to this day is keratoconus. And so because that's declining, it's definitely been cited in literature several times that it's due to the institution of corneal cross-linking. And we're seeing that, there have been 25% fewer PKs following 3 years after cross-linking was introduced compared to the 3 years previous. We're seeing in retrospective studies that we're able to keep patients in lenses longer, especially in severe diseases. And, with that, it's less risk for the patient. So if we can diagnose early and stabilize the cornea, then we can do better with lenses and keep our patients seeing and doing what they need to do longer. But at the end of the day, there are some times that we need to refer these patients. And I would encourage all of you out there that, before you make that referral, make sure that you've tried on some sort of gas permeable lens for a transplant. Make sure that you've over-refracted through some sort of gas perm lens or a scleral lens. See what that vision can be. And I don't know how your practice is, Melissa, but I know my corneal surgeons, before they see a patient for a cornea transplant, if a patient's been referred in for a consult and they find that a patient's not tried a scleral lens, they at least refer them to me to at least put on a lens and over-refract. Because the one thing I would say is never judge a cornea by its cover, because you'll be amazed at how bad the cornea can look and how bad the scarring is. And then all of a sudden they're 20/40 or 20/20. So the reasons why we refer for cornea transplant is mainly because of scarring, because vision is insufficient in lenses. The other reason is because we can't fit these patients with lenses anymore. But thanks to all this advanced technology in sclerals, we're able to keep patients in lenses longer. But at the same time, there can be some health issues of the cornea that preclude patients from able to enjoy this technology. And so that may be a time to refer. And so there is still a place for that, but hopefully with all of this technology and this information, we're finding that we're needing that less and less. So thank you for your time and attention.